Good day, all. In this talk, as part of my series of talks on health and healthcare, I shall examine the history of nursing. I shall focus primarily on Canada, but I shall begin with a brief look at the origins of nursing in Britain. The history of modern nursing begins, of course, with Florence Nightingale. Before Nightingale, nursing was performed by nuns and untrained volunteer charity workers. Nightingale professionalized nursing, making it into a paid occupation requiring vocational education. Nightingale was born into a wealthy family in England in 1820, and she quickly demonstrated her strong will and independence by refusing to become the happy little homemaker her family expected her to be. Instead, over her family's protests, she studied medicine and became the director of a nursing home, which she in effect transformed into an efficient little hospital. She became famous for her work in the Crimean War of 1853 to 56, where her nightly lamplit rounds of her patients earned her the nickname the Lady with the Lamp. However, when Nightingale and her group of personally trained nurses first arrived in the Crimea, which is in southern Russia, they were met with hostility by the male military doctors already there. As I said in a previous talk, the 19th century was the time when doctors were fighting to establish a monopoly on healthcare, and so at first they saw these new nurses as potential competitors. Nightingale had to reassure the doctors that a nurse was a doctor's handmaiden, his obedient assistant, only there to follow his orders and to do women's work, like cooking and cleaning for the patients. In this way, Nightingale was able to introduce proper standards of nutrition and sanitation, both of which conventional male medicine was still ignoring, but which Nightingale knew the importance of. There was one famous example where Nightingale noticed that anyone who drank water from the river got sick. So, she organized an expedition upriver where they found a dead horse in the river, just spewing out all kinds of bacteria. Getting the horse removed and generally cleaning up the camp dramatically lowered the soldiers' mortality rates and made her a public heroine back in England. Unfortunately, the war took a heavy toll on Nightingale's own health. After her return to England, she was mostly bedridden for the rest of her life. However, she didn't let that keep her down. She became a well-known writer, making major contributions to germ theory. She also became a political activist, firing off letters to politicians on healthcare issues. And above all, she continued to organize her nurses, laying the foundations for modern nurse training and modern nursing. In Canada, the first nursing school on the Nightingale model was established in St. Catharines, Ontario in 1874. At that time, nursing was virtually the only paid occupation which was legitimately open to women. This made it very attractive to women, especially middle-class women, with aspirations towards an education and a career. The number of nursing schools grew slowly at first, but then exploded in the early 20th century. In the year 1900, Canada had 20 nursing schools, but by 1910 it had 170, and by 1930 it had 220. Moreover, in 1919, following the recommendations of the Flexner Report, the first university degree program in nursing was established at the University of British Columbia. This growth in nursing education naturally meant a dramatic growth in the number of nurses. In 1900, Canada had only just over 200 nurses as compared to over 5,000 doctors. By 1930, Canada had over 30,000 nurses as compared to over 10,000 doctors. After this, the rate of growth in nursing declined, but still, for most of the 20th century, nursing maintained an average annual increase in workforce of over 50%, compared to under 10% for doctors. By 2006, Canada had over 320,000 nurses, making up about 2/3 of all healthcare providers. Nursing has become the single largest profession in Canada, and about 95% of nurses are women. Altogether, about 80% of healthcare providers are women, which means that today, as it has been through most of history, most healthcare work is done by women. The problem is that women's influence within the healthcare system has not grown in proportion to their numbers. In the late 19th and early 20th centuries, nursing was virtually women's only route to economic independence, other than inheritance. But it was a hard road to travel, and it gave only a very limited degree of independence. Nightingale's teaching methods required strict obedience to senior nurses and doctors. Some feminists have criticized Nightingale's acceptance of male authority in this way, but others have countered that this strict obedience was the only way to overcome doctors' initial hostility towards nurses. It reproduced the patriarchal family relations of the time within the healthcare system. In the home, the husband was in charge, and the wife was basically his domestic servant, responsible for cooking, cleaning, and childcare. In the hospital, the doctor was in charge, and the nurse was his obedient servant, responsible for cooking, cleaning, and patient care. This meant that a new gender division of labor emerged in healthcare based on what I call the 4 C's. Men provided cuts and chemicals, or surgery and pharmaceuticals, and women provided cooking and cleaning, or nutrition and sanitation. Or to put it another way, doctors provided the cures, nurses provided the care. In its own way, it's a reasonable division of labor. The problem, of course, was that men ended up taking most of the money and power, and women ended up doing most of the work. In particular, nursing students were used by hospitals as virtual slave labor. Early nursing schools provided little in the way of teaching and even less time for study. Instead, there was just so-called on-the-job training. In other words, the students were put to work. They worked 12 and even 16-hour days, mostly doing hard manual labor, scrubbing floors and windows, changing beds, doing laundry, cooking in large quantities, and so on. Like slaves, they were not paid for this work. They received only room and board and training, if you can call it that. This meant that nursing schools provided hospitals with a rotating pool of cheap labor. Each student would provide 2 to 3 years of unpaid labor before graduating. Hospitals only had to pay for a small permanent staff of senior graduate nurses to supervise the students. This tells us that the explosive growth in nursing schools in the early 20th century was in part to provide unpaid student labor to hospitals. However, once nurses became a permanent part of hospital staff, they transformed both the reality and the public image of hospitals. Before the introduction of nursing staff, hospitals were filthy and disease-ridden places. They were seen by the general public as places you took people to die. After nurses had cleaned them up, hospitals became hygienic centers where people were taken for care and recovery. Nurses made hospitals into places where the general public would actually want to go. Once they graduated, nursing students could look for a job in a hospital or as a private nurse. But even if they got a job, their average income was barely half that of the average male wage. From the very start, nurses were underpaid and overworked. In order to improve their situation, nurses got organized. In 1908, they formed the Canadian National Association of Trained Nurses, which in 1924 was renamed the Canadian Nurses Association, the CNA, which remains nurses' main organization to this day. The first goal of the CNA was to ensure that only trained graduate nurses could work as nurses. In other words, they wanted to establish a legal monopoly on the position of assistant caregiver, just as doctors had established a monopoly on the position of primary caregiver. To this end, in 1910, they began to establish provincial registries of qualified nurses. Only those persons whose names were on the registry were registered nurses, or RNs, and so had the legal right to work as nurses. By World War II, the CNA got nurses' official workday down to 8 hours, and after World War II, it began to press for significant pay increases with some success. In 1950, with men earning close to double what women did, nurses' pay was just 60% of the Canadian average. But by 1980, nurses' pay had reached the Canadian average, which is where it still is. As of 2017, the average nurse's wage was between $65,000 and $75,000 a year. In the 50s and 60s, in addition to better pay, nurses began to press for better education. In this, they were supported by the 1964 Royal Commission's Hall Report, which was extremely critical of nurses' education, declaring that it was still more about providing cheap labor for hospitals than about providing students with knowledge and training. The Royal Commission recommended completely separating nurse training from hospital demands for nursing services. As a result, in the late 60s and early 70s, most nursing education moved from hospital schools to newly created diploma programs at community colleges and universities. This led to a significant improvement in nursing education and nursing standards. However, I have been told by my students that nursing students are still sometimes used as unpaid labor by hospitals. Despite the steady growth in the number of nurses, the swift expansion of healthcare in the 50s and 60s led to a nurse shortage. So, the federal government changed its immigration policy to attract more nurses from abroad. In the late 60s and early 70s, some 20,000 nurses immigrated to Canada, many of them products of the British National Health System, the NHS. The federal government quite deliberately attempted to expand and upgrade Canadian nurses by recruiting from the birthplace of modern nursing, Britain. This, in turn, was part of a larger project of establishing Medicare by copying Britain's NHS which had pioneered state-run healthcare. This period of expansion in nursing was also a period of growing division of labour. That is to say, it was a period of growing specialisation, fragmentation, and hierarchisation. Just as nursing was an auxiliary occupation to that of doctor, so too nursing now began to generate its own auxiliary occupations. Orderlies, therapists, technicians, dietitians, and so on. Also, nursing was broken down into different categories of nurse. As a result, some nurses went back to school, upgraded their qualifications, and then specialized. But not that many. Specialist nurses earn only marginally more than general duty nurses, so going back to school doesn't really pay off. About 3/4 of nurses are still general duty nurses. The 70s also saw nurses face a challenge from hospital administration. Because, as I said before, this was a time when nurses' wages were rising. And the problem with that was that it prompted hospitals to look for cheaper alternatives. This is, of course, something that happens in every area of the economy. Employers always want to replace expensive skilled labour with cheaper, semi-skilled or even unskilled labour if they can. So, in the 70s, many nurses were replaced with semi-skilled registered nursing assistants. However, within just a few years, they got organised and got their pay increased. So in the late 80s, many of them were replaced by still cheaper nursing attendants. This is class struggle in action. Workers get organised and raise their pay, so management reorganises and lowers their pay, so the workers organise again, and the cycle continues indefinitely. It's a built-in part of capitalism which can be seen in any area of the economy. Where the 60s and 70s saw a major growth in nursing, the 80s and 90s saw a major growth in healthcare administration, especially hospital administration. From 1981 to 1986, the number of healthcare administrators grew by over 2/3. By 1990, the average hospital's wage bill broke down roughly into thirds. 1/3 for doctors, 1/3 for nurses, and 1/3 for administrative and support staff. The reason for this growth in administration was that the federal government had decided to bring in a new kind of administrator into healthcare. Before the 80s, almost all hospital administrators were doctors and other healthcare staff who had gradually climbed the hospital's administrative ladder internally. But the new administrators had no previous experience with the healthcare system. Rather, they were managers brought over from the private sector and put in charge. The rationale was that they'd be able to use their private sector experience to make some tough economic decisions and cut costs at a time when the government was introducing cutbacks to healthcare. By 1993, almost half of healthcare administrators had no clinical experience. Doctors and healthcare workers in general largely lost control of their hospitals to these new private sector administrators. The new administrators did not just sit around. They swiftly introduced major changes into Canadian healthcare. They did what they were expected to do. They introduced private sector techniques into healthcare. First of all, they introduced clear lines of authority based on capitalism's class structure. The administrators were the upper class, the doctors were the middle class, and the nurses and everyone else were the working class. Or in other terms, the administrators became upper management, and the doctors became middle management, while the rest became workers. Generally, the administrators would sit in their offices and make decisions which they knew would be unpopular with the staff, but they'd let the doctors take the heat because the doctors were the ones in regular contact with the other healthcare staff. Doctors felt some of the pressure of cutbacks at this time. Surveys showed that doctors had to work harder and see more patients to maintain their high incomes, but that they were able to do so. Being seen as middle-class professionals gained them respect, both from administrators and politicians, so they were not pressured too much. Not so for nurses. Despite the steady rise in nursing education and nursing skills, which I would argue makes them also middle-class professionals, the new administrators treated nurses as working class. And what private management specializes in is squeezing as much work as possible out of the working class. One way in which this is done is by a process termed de-skilling. We've already looked at part of this process because it involves replacing skilled workers with cheaper, unskilled workers. It's called de-skilling because it is reducing the skill level of the workers who do the job. However, in order to do that, it is often necessary to break down a complex job, which only a skilled worker can do, into a lot of simple little jobs which unskilled workers can be quickly trained to do. This is an idea that's been around for as long as industrial capitalism, and it's gone through several different names. In the early 19th century, it was called the Babbage Principle, after Sir Charles Babbage, the first economist to write about it. In the late 19th century, it was called Fordism, because Henry Ford used the idea to invent the assembly line. In the early 20th century, it was called Taylorism, after Frederick Winslow Taylor, who invented scientific management, which was based on time and motion studies, which examined every move a worker made and how much time it took. And in the late 20th century, it became known as McDonaldization, because McDonald's has their restaurants organized with timers and buzzers and bells so that they can take unskilled teenagers and put them to work right away. Within the field of healthcare, this process has also gone by several different names. It's been referred to as managerial ideology, management technology, and case mix groupings. But the most commonly used name is total quality management, or TQM. TQM breaks down nursing into specific tasks like changing bandages, changing beds, giving a bed bath, and so on. Nurses are then given a specific amount of time to perform each task. When TQM was introduced, nurses were told that it would make their jobs easier by improving efficiency, and that it would give nurses greater autonomy and control over their own work process. But this turned out to be the exact opposite of the truth. In fact, TQM greatly increased both nurses' workload and their level of supervision. The administration took total control over nurses' work. They had a job assigned for every minute of every day. This micromanaging took away nurses' freedom completely, which is why I would argue that TQM really stands for totalitarian quality management. because it is a dictatorial way of running things. TQM not only took away nurses' freedom, it also squeezed them to work harder. When the system was first introduced, the time allotted for each task was established by polls which the nurses filled out. Nurses' cooperation was secured by telling them that this would help the hospital to assess staffing needs so that they could make sure there were always enough nurses. But once the system was in place, its real purpose was revealed. The administration began to arbitrarily cut the amount of time allocated for each task. One year you might have 30 minutes to do something, the next year you have 20 minutes, the year after that just 10 minutes. Nurses were forced to work harder and faster, which meant that they didn't need to hire so many of them. This is fine in a factory, but it's not such a good idea in a hospital. TQM treats patients and nurses as if they were on an assembly line. Everyone is put through a process of standardization. Every patient is supposed to be treated for the same thing in the same amount of time. The problem is, people are not machines. They cannot be standardized. For example, a young, relatively mobile patient can get a bed bath in just a few minutes. But an old patient with arthritis, who moans and groans every time you move them, can take closer to an hour. TQM takes no account of the fact that some patients take a lot more time than the average patient. And that puts a lot of time pressure on nurses. They're constantly in a hurry, constantly falling behind the unrealistic schedule that the administration has set for them. This is a problem particularly because part of a nurse's job is to make decisions about the treatments and medications which the patient will receive. When the nurse only has split seconds to make those decisions because she's already thinking about her next case, it is inevitable that mistakes will rise. And they have. According to a 2004 study by the Canadian Institute for Health Information, over 5 million Canadians, or nearly a quarter of Canadian adults, reported that they or a member of their family had been harmed by medical errors while in hospital. 1 in 9 adults had received incorrect medication or an incorrect dosage of medication. 1 in 9 adults and 1 in 11 children contracted an infection. 1 in 80 newborn babies suffered birth trauma. 1 in just over 1,000 seniors suffered a hip fracture. And, my personal favourite, 1 in just under 7,000 patients had a foreign object accidentally left inside them after a surgical procedure. One of the causes of these growing errors is that TQM treats nurses as if they were interchangeable components, like machine parts. Different nurses are assigned to do different jobs for the same patient. This means that there is no continuity of healthcare. There is no one nurse who knows the patient's overall health situation or can even get to know the patient as a human being. TQM is very much a male approach that has been forced onto women. TQM is an extension of the mechanical model of treating specific problems and a denial of the traditional female holistic approach to healthcare. TQM turns the continuous process of care into a series of compartmentalized mini-cures. But in doing so, TQM sees to patients' objective needs, but completely ignores their subjective needs. Nurses do not just change bandages and give shots. They also talk to patients, they address their concerns, they calm their anxieties. Sometimes they just hold them while they cry. Because if you're in a hospital, then you have some sort of serious health problem. And that's scary. Comforting scared patients is a part of a nurse's job that sociologists call emotional labor. But it's a form of labor that hospital administrators refuse to acknowledge because they can't charge for it. To a private sector manager who only sees a balance sheet with dollars and cents, the comfort that nurses provide is invisible. He considers it wasted time, so he uses TQM to eliminate it. In short, TQM is about taking the care out of healthcare. I would argue that the factory-style micromanagement introduced by TQM is completely inappropriate for nurses, precisely because they're not unskilled workers. They are educated professionals. The days when nursing primarily consisted of cooking and cleaning are long gone. These days, nurses operate complex equipment, assign medication which requires precise dosages, and provide a variety of advanced treatments. They are highly skilled workers, not manual laborers. And this makes a difference. Studies show that most manual workers are content to just follow orders in the workplace as long as those orders are reasonable. But most educated professionals are not content unless they control their own labor process. The whole point of getting an education is so that you know best how to do your job. You are the expert in the field. You know what needs to be done, not some administrator sitting in an office. So, when administrators start trying to tell educated professionals like nurses how to do their job, it quickly results in a very dissatisfied workforce. In a word, TQM greatly increased nurses' alienation from their job. Nursing has always been a profession with a very high level of personal commitment. Nurses have people's health and even their lives in their hands, and the overwhelming majority of nurses takes that responsibility very seriously. But TQM often forced nurses to not do their job as well as they would have liked, by not giving them the time or the resources to do their job properly. Healthcare standards declined in Canada's hospitals through the 80s and 90s. With administrators introducing TQM instead of hiring more nurses, a nurse shortage developed. With nurses rushing from job to job, many patients were not receiving the care they needed because there just weren't enough nursing hands to go around. Nurses knew that this was happening and were not happy about it, but there was very little they could do. Thanks to the unrealistic TQM schedule, nurses were behind in their work almost from the moment they arrived, and spent the whole day playing catch-up and never quite making it. As a result, the morale of the nursing profession declined dramatically. Some nurses blamed themselves for being unable to keep up and so got depressed. Others blamed other nurses and got angry. Either way, this led to a growing psychological stress, which combined with the growing physical stress from TQM's increased workload, to result in a growing number of work-related injuries and illnesses. Ironically, by the 90s, nursing had become by far the sickest profession in Canada. In 1997, the average Canadian worker lost just under 1 week in the year on sick leave, but the average nurse lost over 3 weeks. As a result of all this, the 90s witnessed the swift growth of a phenomenon almost unheard of previously: nurse burnout, where increasing numbers of nurses quit the profession because they just couldn't handle the pressure. The result of this was a high rate of turnover in hospital nursing staff and nurse shortages in some places. In surveys, some nurses reported that they quit because they could see themselves making mistakes, and they decided to get out before they made a mistake that cost someone their life. A study published in the year 2000 by the CNA found that of those nurses who had graduated over the previous 5 years, nearly 1 in 3 had already left Canadian nursing. About 10% had gone to work in the US, but about 20% had simply quit nursing altogether. Similarly, the 90s also saw a sharp decline in the number of applicants and graduates to and from nursing schools. In 1990, almost 9,000 nurses graduated in Canada. In the year 2000, that was down to less than 5,000. There has been an increase in this number in the 21st century, but still, the average age of nurses has been rising as the profession has become less attractive to young people, especially young women. 100 years ago, nursing was practically the only option a woman had if she wanted to work. Today, women have all kinds of other employment opportunities, so they don't have to put up with the stress that nurses work under. In support of what I've been saying about nursing, I have a letter which was published in our local newspaper, the Leader Post, in 2010. The letter is from Ms. Deirdre Young, a retired nurse living in Swift Current, Saskatchewan. To be clear, I do not know Ms. Young, I have never met her, and I certainly didn't ask her to write this letter. But I want to read it to you because it backs up every word that I've just been saying about the problems faced by Canadian nurses. So, Ms. Young, as a retired registered nurse who was recruited from England in 1960 because of a nursing shortage and spent another 47 years in the healthcare system, I feel I need to speak on the current situation. I retired from hospital care to a doctor's office in 1998 because of the so-called healthcare reform, which I prefer to call healthcare destruction, as I felt unable to function within the changes. All nursing unit manager positions were dissolved in favor of 2 or 3 supervisory positions carrying large responsibilities which removed them from the wards. This resulted in a lack of leadership and support for the general duty nurses. Morale plummeted and has never recovered. You can't run a ship without a captain. This creates unhappy staff, resulting in increased sick time and a lower level of patient care. I am in touch with many hospital staff from various departments, and all they think about is when they can retire. I find this depressing, as I loved every day I went to work. Government decisions totally changed healthcare as we knew it. a large number of highly paid director positions were introduced. Most of these people had no medical knowledge or understanding of patient needs. Yet these same people made radical changes to the running of hospitals, causing ongoing dysfunction to this day. I am disgusted to read about the overtime and salaries some nurses are taking home. I can't say earning, as they're obviously not rested and therefore not capable of giving the quality care for which they're paid. This is where mistakes are made that can cause serious harm to patients. The running of the healthcare system should be put back into the hands of people who are competent and knowledgeable in this field, so healthcare workers can enjoy going to work again. Ms. Young is talking here about the changes introduced through TQM in the 80s and 90s, changes which she calls healthcare destruction. This is perhaps a bit of an exaggeration, but there can be no doubting the harmful consequences it has had for both nurses and patients. Nurses fought back against these changes in healthcare as best they could. In the late 80s, the CNA and provincial nurses' unions issued statements declaring that the combination of cutbacks and TQM was endangering patients' lives. Some unions went further and took a stand on what were called safety to practice issues. Nurses' strikes broke out in Saskatchewan and Alberta in 1988, British Columbia and Quebec in 1989, and the strike wave culminated in the longest nursing strike in Canadian history in Manitoba in 1991. However, while the strikes gained the nurses considerable public sympathy, they gained very few concessions from their new administrators. The nurses did get so-called professional responsibility clauses put into their contracts, which established formal channels through which nurses could express their grievances. However, these grievances were then just ignored and nothing changed. So, in the late 90s and early 2000s, there was a fresh wave of nurses' strikes, this time hitting every single province in Canada, including Saskatchewan. Saskatchewan nurses went on strike in 1999. At that time, Saskatchewan had an NDP government led by Premier Roy Romanow. This was the party of Tommy Douglas, the party that had given Canada Medicare, the party, supposedly, of the left. But by the 90s, that party had changed. The NDP dealt with the nurses just like a Conservative government would have done. They enacted back-to-work legislation, declared the nurses' strike illegal, and threatened the union with huge fines and the union leaders with jail time if they didn't go back to work. In the end, it didn't come to that. The nurses went back to work in exchange for modest pay increases and promises that more nurses would be hired to alleviate the shortage. But while the government has made some efforts to recruit more nurses, nurses continue to be overworked all across Canada. In 2003, Canadian nurses worked about 250,000 hours of overtime weekly, equivalent to about 7,000 full-time positions. In other words, in 2003, our healthcare system needed another 7,000 nurses. The government keeps promising more nurses, but nurses keep being overworked and overstressed, and nurse burnout keeps rising. A 2005 study of Ontario nurses found that 58% of all registered nurses and 66% of junior registered nurses were experiencing symptoms of nurse burnout. These symptoms included depression, emotional exhaustion, physical exhaustion, physical illness, and a growing cynicism about the job. The reasons the nurses gave for these were work overload, lack of empowerment in the workplace, and lack of fairness in the workplace. In other words, they were being unfairly overworked, and there was nothing they could do about it because the administration had taken control of their jobs out of their hands. Many said that they were being put into a situation where they could no longer do their jobs properly. The study found that about 1 in 3 nurses under the age of 30 were planning on leaving the profession, and about 1 in 3 nurses over the age of 50 were planning on taking early retirement. On a brief personal note to back this up, my wife Amanda is a 2-time breast cancer survivor, so I've spent more time than I'd like in hospitals. And one thing I noticed a long time ago was the dramatic difference in attitude between young nurses and older nurses. Young nurses, just starting out, are all excited and happy and smiling. Older nurses, who've been doing the job for years, are not like that. They're tired, depressed, and cynical. And, just as Ms. Young said, all they want to talk about is retirement. They all seem to be just counting the days until they can retire. Although the 21st century has seen some increases in funding and staffing, Canada continues to have a nursing shortage. Nursing continues to be hard, stressful work, and it is not as appealing to many young women as it used to be, since they now have other alternatives. Underfunding by both federal and provincial governments continues to make nurses' jobs difficult. In an attempt to address these difficulties, the Saskatchewan government stepped up in 2012 and once more introduced a new kind of healthcare to Canada: lean healthcare. In 2012, Premier Brad Wall announced that Saskatchewan was once again leading the way for all of Canada in improving healthcare, because in 2012, Saskatchewan became the first province in Canada to introduce lean management into the field of healthcare. To be precise, Saskatchewan signed a 4-year contract with Seattle-based John Black & Associates at $10 million a year to teach lean techniques at over 1,000 healthcare facilities in Saskatchewan. Most of the teaching was done by experts or senseis flown in from Japan. But in 2014, the government came under heavy criticism for the project's high price tag. Opposition leader Cam Broughton even went so far as to call lean a cult. As a result, the Saskatchewan Party cancelled its contract with John Black after just 2 years. The Saskatchewan Party says lean will continue, but only about 200 people have been trained in lean instead of the 880 that John Black was originally supposed to train. Altogether, implementing lean cost between $45 and $50 million, about half of which went on consultant fees to John Black. But lean was supposed to save the province money overall by increasing efficiency, reducing waste, and above all, finding quicker ways to do things so as to reduce health workers' workload. Did it do so? Depends who you ask. Premier Wall said in 2014 that lean saved Saskatchewan $35 million by reorganizing blood services. But management there responded that this reorganization took place before lean was implemented and had nothing to do with it. The Premier also said that lean saved millions more in hundreds of small savings across the province. But the provincial auditor could find no evidence of this. John Black have claimed that lean reduced staff hours by over 15,000 hours, which avoided hiring over 1,000 new workers and led to a net savings of some $7.5 million. But Thomas Rotter, a researcher then at the University of Saskatchewan, says that John Black's numbers have no scientific basis and have just been made up out of thin air. According to Rotter's surveys, 75% of nurses and 42% of other healthcare professionals said their workloads increased under lean, and 17% of nurses and 48% of other professionals saw no change. So altogether, less than 10% of all healthcare workers said lean actually reduced their work hours. Rotter concluded that lean has led to some improvements to Saskatchewan healthcare and some monetary savings, but nowhere near what's been claimed by the Saskatchewan Party and John Black. It turns out that politicians and businessmen tend to greatly exaggerate their accomplishments. Surprise, surprise. So, just what is lean management? Well, lean management was invented by Toyota Automotive Corporation in Japan, except that they don't call it lean management. That term was invented by the American John Krafjic in an article he wrote about Toyota in 1988, which introduced the idea to the West. But Toyota just calls what they're doing the Toyota way. And the Toyota way certainly seems to work for Toyota. Toyota was founded in the 1930s as a small family business and has grown to be the 5th largest corporation in the world. So clearly, they are doing something right. Moreover, Toyota loves to teach about the Toyota way. And worldwide, literally thousands of businesses, large and small, have adopted it. However, of those thousands of businesses, only Honda and a handful of others have stuck with it over the long term. For the rest, a pattern has emerged. First, lean management is introduced and has some immediate successes. A number of inefficiencies are identified and eliminated, techniques are changed, and often quite dramatic improvements take place in terms of doing certain things faster and cheaper. However, after a few years, the enthusiasm wears off, the expert advisors go home, and new kinds of inefficiency and waste start to enter the system, so that after a few more years, you're pretty much back where you started. This is what seems to be happening in Saskatchewan. How is it that Toyota can make their way work over the long term, but so few others can? Well, to answer that, we need to learn a bit more about the Toyota way. Toyota began building cars in the 1930s, basing itself on Henry Ford's assembly line techniques. Like Ford, Toyota was greatly concerned with efficiency and elimination of waste. So, the Toyota way is an extension of Fordism and Frederick Taylor's scientific management or time and motion studies. Toyota's basic idea is that the production process should flow smoothly, with no bottlenecks or unused resources. This is often referred to as the just-in-time system. Each person does their part of the job just in time for the next person to take over. This means that you don't need to keep a lot of backup inventory just waiting to be used, which allows you to save money. The production process is standardized and simplified, eliminating both waste effort and waste resources, which is all good. The problem is that when other companies adopt lean management, they tend to think that it's just about the shop floor time and labor saving techniques. But it's not. As the name implies, lean management is first and foremost a managerial philosophy, which means that for it to work, the people who primarily have to change their way of thinking are the managers, not the workers. Lean management establishes a culture where everyone is committed to constantly looking for ways to improve the production process. Management has regular meetings with workers so that together they're constantly looking for ways to do things better. Lean management emphasizes teamwork and mutual respect between management and employees. Management consults with workers and gets regular feedback from workers. Decisions about changes are made by consensus within these meetings. What Toyota discovered here is basically that if workers' opinions are respected and they're more involved in decision making, then they feel more like the company is their company. And so they want to be more efficient and find ways to do their jobs better. Management and workers work together as a team, so they think of themselves as a team. You create the feeling that the company is one big happy family. So instead of fighting management, the workers help management. It is that positive attitude that is the main thing. Toyota explicitly says that specific time-saving techniques are just byproducts of this attitude. If the whole workforce is looking for ways to improve things, then they will. Exactly which techniques they come up with is secondary. This system works well in Japan. It works because Japanese culture emphasizes mutual respect, which includes respect between management and workers. The problem is that North American culture does not. As far as most North American managers are concerned, management gives the orders and the workers do as they're told. Most managers don't want to listen to their workers even once, let alone on an ongoing basis. So, they hire Toyota's experts to come up with some labor-saving techniques, order the workers to implement them in a completely top-down manner, and then go back to their offices happy that they've improved efficiency. But in most places, as in Saskatchewan, no consultation is ever made with the workforce, which is why no long-term commitment to the system appears. And after the senseis go home, all that's left is a few techniques which become increasingly obsolete as technology changes. In Saskatchewan, nurses were told that lean would be introduced in a process of consultation with nurses. But the Saskatchewan Union of Nurses has stated that no such consultation actually happened. Instead, Japanese experts with clipboards came around, made their time and motion type studies, and then just told nurses what to do. And to add insult to injury, they told them what to do, partly in Japanese. Management did not see it as their responsibility to translate Japanese terminology into English. Oh no, it was the nurse's responsibility to learn Japanese, even though that is hardly in their job description. John Black himself even wrote that Saskatchewan nurses' objections to learning Japanese terminology, quote, carried racist overtones, unquote. It is that kind of insulting, top-down arrogance that quickly alienated most of Saskatchewan's nurses, which meant that there was no chance of creating the kind of workforce support that lean is really based on. Instead, lean became just an extension of TQM, authoritarian workplace decisions delivered from on high. Administrators and senseis who, prior to their arrival, knew nothing about how healthcare worked, were suddenly telling nurses how to do their jobs. In addition, there are other problems with applying lean management to healthcare, because, like all factory-style management, lean was originally invented to provide goods, not services. In other words, it was intended to work on products or things, not people. And most of the companies who've tried it have used it in factories to improve productivity. What Saskatchewan did was by far the largest experiment ever in applying lean management to the delivery of any kind of service, such as healthcare. And this was bound to lead to problems. First of all, just as I said about TQM, lean management also works partly by emphasizing standardization. This works great for machines, but you can't standardize people. Patients need customized care, not standardized care. Every individual's healthcare needs are slightly different, so you can't standardize healthcare delivery the way you can factory production without harming patients' health. And secondly, the lean principle of just in time is great, as long as it works. But if just one link in the chain gets broken, if one person does not do their job in time, then just in time becomes not in time. Now, in a factory, that means that some part of the production process gets temporarily halted or slowed down. This costs the company money, but the occasional glitch is acceptable since the system as a whole is still making them money. However, if healthcare is not in time, then you're endangering people's health and even their lives. Similarly, lean management is called lean partly because one of the things it does is to eliminate inventory. You have just as many supplies as you need with no backup stores because lean says unused inventory is just waste. Now this works fine in a factory where supply needs are pretty predictable, so you can order everything just in time. But healthcare is not so predictable. There are many things in hospitals that you don't need every day, but when you do need them, you need them right away, or people can die. But in a 2014 survey, about half of Saskatchewan's nurses said that both the quantity and quality of supplies available had declined since the introduction of lean. Vital equipment is sometimes missing, and needed medications are not available. In short, cutting inventory to the bone, as has now been done across Saskatchewan, saves money but endangers lives. Unfortunately, the introduction of lean was always more about saving money than improving patient care. Before lean was introduced, the provincial healthcare budget was normally increased by between 7 and 10% a year. Under lean, the increases were just 3 to 4% a year. The government said that lean had created so many savings that the healthcare budget did not need to increase by as much as in the past. But a report by an independent assessor published in July of 2014 concluded that, in fact, the Wall government had neglected healthcare facilities to the point where the province needed to spend over $2.2 billion just to provide essential repairs to existing buildings that were falling apart. The report rated 87% of Saskatchewan's current healthcare facilities as just poor to fair. Unfortunately, the Wall government ignored this report. So in 2019, the provincial auditor estimated that Saskatchewan now needed to spend over $3.2 billion just on essential repairs to healthcare facilities. What this shows is that lean management has simply been used by the government as a pretext to cut funding for healthcare to the bare minimum. In 2013, when it was first introduced, Saskatchewan Union of Nurses President Tracy Zambori was supportive and said that lean was leading to, quote, many commendable changes. But in 2014, she said that it had already become obvious that the only purpose of these changes was, quote, budgetary savings, and that they had, quote, little impact on direct care at the bedside and patient outcomes. Rotter's survey similarly found that most patients saw no change to their care under lean, and of those who did see a change, about as many viewed it as negative as positive. Zambori even went so far as to say that lean management, with its emphasis on saving money, simply does not fit in to safe nursing practice. Now, lean management has certainly had successes in inventory management, waste reduction, and saving money. It has also been successful in removing unnecessary steps in the healthcare process and thereby speeding up the delivery of healthcare to patients. However, a union survey shows that it also led to an increase in critical incidents in Saskatchewan hospitals between 2012 and 2013. In other words, faster healthcare is not always safer healthcare. My own conclusions on lean are that if it really was done the Toyota way, then it would be a good thing. Because regular consultations between doctors, nurses, and administrators would give frontline healthcare workers more input into the running of hospitals and clinics. Unfortunately, lean done the Saskatchewan Party way is not about improving healthcare. It's about furthering the right-wing neoliberal agenda of taking government money away from social programs and giving it to big business. Lean management provided the Saskatchewan Party with a pretext for cutting inventory, cutting services, and cutting budgets to healthcare, while giving tens of millions of dollars of taxpayers' money to the private sector in the form of John Black and Associates. Ultimately, Lean was just one small part of the creeping privatization of Canada's healthcare system. In conclusion, Lean clearly did little or nothing to help Saskatchewan deal with the coming of COVID. COVID made life much worse for nurses because COVID affected nurses more than anyone else. To say that they were overworked during the pandemic doesn't begin to cover it. By 2022, surveys of Saskatchewan nurses were showing that a staggering 94% were experiencing symptoms of burnout, with almost 50% experiencing clinical burnout, meaning they needed mental health supports. Over 50% are considering leaving the profession. Many have already scaled back their work hours, for example, by declining overtime. This is a vicious circle. The nurse shortage and general lack of resources makes it almost impossible for nurses to do their jobs properly, which leads to nurse burnout and nurses leaving the profession, which worsens the nurse shortage. The only way to break this circle is for federal and provincial governments to devote major funding to increasing the supply of nurses and to improving their working conditions. However, while politicians keep promising to do so, it keeps not happening. In December of 2022, Saskatchewan's provincial auditor submitted a report stating that the province has a shortage of about 2,000 nurses and other caregivers, and that if more is not done to address this shortage, it will continue for at least the next 5 years. This shortage has already led to growing service disruptions and delays, which are causing mounting frustration and anger among patients, which in turn has led to a rise in verbal abuse and even violence directed at nurses and other hospital staff. Tracy Zambori has stated that, quote, Saskatchewan's registered nurses are feeling overwhelmed, exhausted, and unheard. Chronic understaffing has registered nurses working harder than ever in situations that are increasingly dangerous to both healthcare staff and their patients. This pace is unsustainable, but shows no sign of slowing down. Registered nurses arrive for each shift knowing they will be asked to care for too many patients, too quickly, and with too little space and too few resources. They work each shift feeling it's only a matter of time before a mistake is made and a patient is harmed as a result. The situation is particularly bad in rural areas. Zambori has gone so far as to say that, quote, rural health is crumbling. Nurses are getting no breaks in a system that has collapsed, and they're working in the rubble of it. Zambori is concerned that the continuing stories of nurse burnout may just become white noise that the general public tunes out. The reality is that nurse burnout remains high and nursing in Canada remains an occupation in crisis. That concludes what I have to say on nursing in Canada. A transcript of this talk is attached if you're interested. Good day.